Your lab results came back last week, and your eGFR dropped. Maybe it went from 48 to 44, or 52 to 47. Not a huge shift in a single visit, but enough to catch your attention. And now you're wondering, is this normal variation, or is something specific happening in my kidneys? Here's what most people don't realize. A single eGFR change can mean 7 different things. Your doctor isn't guessing. They're systematically checking for specific causes. Some reversible, some not, but all of them worth understanding before your next appointment. In this video, we're walking through the 7 most common reasons your eGFR might be declining, what each one actually looks like in blood and urine tests, and which questions turn a passive lab review into an informed diagnostic conversation with your doctor. Let's start. Most people get their lab results, see a number that's lower than last time, and feel 2 contradictory things at once. This probably doesn't matter, and this definitely matters. Both of those instincts are telling you something real. eGFR is a window into how your kidneys are filtering waste. The question is, what is different, and is it something that can be addressed? That's where most patients stop. They see the lower number and wait for their doctor to explain it. But here's the thing. If you walk in knowing what your doctor is likely investigating, you can ask better questions, catch important details, and catch problems earlier if they exist. You become a partner in your own care instead of waiting to hear what's happening. That's what this video is about. Not telling you that you definitely have or don't have kidney disease, but showing you exactly what doctors look for when eGFR is declining, so you can recognize the signs and have a smarter conversation with your doctor. Let's start with the foundation. What eGFR actually is, and why it's not a fixed number. eGFR stands for Estimated Glomerular Filtration Rate. It's an estimate, and that's an important word, of how many milliliters of blood your kidneys are filtering every minute, adjusted for your body surface area. That number ranges from 90, normal kidney function, down to less than 15, advanced kidney disease requiring dialysis consideration. It's calculated from a blood test measuring creatinine, which is a waste product. So your eGFR can fluctuate. A reading of 48 one month and 45 the next month might be real decline, or it might be normal biological variation. That's why doctors don't panic at one result. They look at the trend over months or years. But when eGFR starts consistently declining, especially faster than the normal aging rate, which is about 1 to 2 milliliters per minute per year, that signals something specific is happening. Now here's where it gets important. eGFR is calculated from your creatinine level, and that calculation makes some assumptions about your body. If you're very muscular, very sedentary, very elderly, or from certain ethnic backgrounds, the calculation can be inaccurate. Sometimes it overestimates your kidney function, sometimes it underestimates it. That's why smart doctors don't rely on eGFR alone. They also look at your actual creatinine level, your blood urea nitrogen, BUN, your urine protein or albumin levels, and sometimes a more direct measure called cystatin C. These tests together paint a clearer picture than eGFR alone. Almost nobody realizes that the very first question a doctor should be asking is whether the test itself might be misleading. Before jumping to, your kidneys are declining, a good doctor checks, could this be a calculation artifact? Is your creatinine actually changing, or just your muscle mass? Could there be a lab error? These are legitimate possibilities, and they explain a percentage of declining eGFR results. But most of the time, a real change in eGFR decline in the population. But the chronic mild dehydration concentrates your blood, which elevates creatinine artificially. Your kidneys are actually filtering fine, but the ratio of creatinine to blood volume makes it look like they're filtering less. This is one of the most commonly missed causes of apparent eGFR decline. Your doctor can usually spot this by asking, are you drinking enough water? What does your blood sodium level look like? Is your blood pressure lower than usual? If the answer is yes to dehydration questions and yes to other dehydration markers, certain medications stress your kidneys acutely, raising creatinine temporarily without actually damaging long-term kidney function. NSAIDs are the most common. Ibuprofen, naproxen, and prescription versions can elevate creatinine if taken regularly. Some antibiotics do this. Certain blood pressure medications in high doses can reduce kidney blood flow acutely. Diuretics that cause dehydration can elevate creatinine. If your eGFR dropped shortly after starting a new medication, that's a legitimate red flag to discuss with your doctor. The third reversible cause is a urinary tract infection or acute illness. Infections, fever, or recent significant illness can temporarily elevate creatinine. Your eGFR might drop during or just after an infection, then recover as you heal. This is why doctors often recommend retesting after you've recovered from infection or illness. You might see eGFR improve. Here's one detail most people miss. Acute kidney injury, AKI, can look like eGFR decline, but is actually reversible. AKI happens suddenly. Your kidneys temporarily filter less because of an acute insult, severe dehydration, medication toxicity, contrast dye from a medical procedure. eGFR can recover completely once the acute problem is addressed. That's different from chronic kidney disease, which develops slowly and is usually irreversible. The distinction matters enormously for prognosis. Now, the confusing part. Sometimes your eGFR drops not because your kidneys are actually worse, but because the calculation itself is different. Maybe you lost muscle mass because of illness or age. Maybe your race or ethnic background wasn't accurately captured in the initial eGFR formula, and a newer formula is more accurate. Maybe the lab itself was slightly off on the first measurement. These are real reasons eGFR can appear to decline without your kidney function actually changing. This is why the very first conversation with your doctor about declining eGFR should include, could this be dehydration? Could this be a medication side effect? Could this be an acute problem that's reversible? Could this be a lab error or calculation artifact? If the answer to any of these is yes, that shapes the entire investigation that follows. But in most cases of consistent eGFR decline, the answer to these questions is no. And that's when your doctor moves into investigating the non-reversible reasons. Before we dive into the specific reasons for eGFR decline, let's talk about what your doctor is actually ordering and what those tests reveal. The foundation is the basic metabolic panel. That's your creatinine, BUN, blood urea nitrogen, and electrolytes. From that panel, eGFR is calculated. But smart doctors also order a urine test, specifically looking for protein or albumin. This is critical information because how your kidneys are declining matters as much as how much they're declining. If your eGFR is dropping but you have no protein in your urine, that suggests a certain class of causes. If you have significant protein in your urine, that suggests a certain class of causes. If you have significant protein in your urine, that suggests a certain class of causes. No protein can mean the problem is elsewhere. Your blood vessels, your heart's output, your medication, rather than in the kidney filters themselves. Some doctors also order a cystatin C test, which measures kidney function through a different biological marker. Cystatin C isn't affected by muscle mass the way creatinine is, so it can be more accurate in very muscular, very sedentary, or very elderly patients. If your creatinine-based eGFR doesn't match how you feel or what your cystatin C shows, that's valuable diagnostic information. If your eGFR is dropping and your blood pressure is normal or low, that suggests a different cause. Blood glucose is tested, especially fasting glucose and A1C. These indicate whether diabetes is developing or progressing. Diabetes is the leading cause of kidney disease in the developed world, so if your glucose levels are rising along with your eGFR decline, that's a major clue. Your doctor might also check your cholesterol profile, your electrolytes in detail, sodium, potassium, bicarbonate, and sometimes your blood calcium and phosphorus if they suspect more advanced kidney disease. Some patients need imaging, an ultrasound of the kidneys to check their size and structure. Small kidneys suggest chronic kidney disease. Normal-sized kidneys suggest more acute problems. The key point, your doctor isn't ordering random tests. They're building a diagnostic picture. Protein in urine plus diabetes plus elevated blood pressure plus declining eGFR tells a different story than declining eGFR with normal blood pressure, no diabetes, and no protein in urine. This is why it's valuable for you to understand what your doctor is checking. When they order tests, you'll recognize what they're investigating. When you get results back, you'll know why they matter. When eGFR decline is real and not reversible, it almost always falls into one of four categories. Understanding these helps you predict what your doctor is investigating. The first category is diabetes-related kidney disease. Diabetes is the leading cause of kidney disease in developed countries. High blood glucose damages the small blood vessels in your kidneys that do the filtering. This damage develops silently over years. Early on, you might see protein appear in your urine before eGFR starts dropping. Later, eGFR begins to decline. What your doctor is checking is your A1C, 3-month glucose average, above target? Is there protein in your urine before eGFR starts dropping? Later, the progression of diabetes-related kidney disease is somewhat predictable, and managing glucose and blood pressure aggressively can slow it significantly. This is one of the categories where active management matters most. The second category is hypertension-related kidney damage. Chronic high blood pressure damages the small blood vessels in your kidneys. Over years, this leads to declining eGFR. What your doctor checks: is your blood pressure consistently above target? Are your kidney function and blood pressure decline happening together? Is there proteinuria? The good news: blood pressure-related kidney damage can often be slowed significantly with aggressive BP control and specific classes of blood pressure medications, AC inhibitors and ARBs, that protect kidney function beyond just lowering pressure. The third category is chronic kidney disease from other causes, meaning your kidneys have underlying structural or inflammatory disease that's causing the decline. This might be from previous kidney infections, autoimmune diseases, genetic kidney diseases, or long-standing obstruction. Does imaging show normal kidney size and structure? Are there signs of autoimmune disease? Did you have previous kidney infections? Is there any family history of kidney disease? Understanding the cause of CKD helps your doctor predict the trajectory and choose the best monitoring and treatment strategy. The fourth category is metabolic or lifestyle-related decline. This includes things like excessive protein intake, puts extra stress on kidneys, chronic dehydration, chronic use of NSAIDs regularly. What's your hydration? What's your weight? Are your triglycerides elevated? Is your uric acid high? Gout risk and kidney stress. Some of these causes are reversible or slowable with lifestyle modification. Here's the critical insight most patients miss. Your eGFR decline probably falls into multiple categories at once. You might have diabetes and high blood pressure and NSAID use and a high-protein diet. Each factor contributes to the decline. Your doctor is likely addressing all of them, not just one. That's why the blood tests, urine tests, imaging, and careful history are so important. They help your doctor figure out which of these four categories apply to you, in what proportions, and what can actually be addressed. They help your Now that you understand what your doctor is investigating, here are the questions that transform a passive lab review into an active diagnostic partnership. First question: is this real decline, or could this be lab variation or a calculation issue? Ask this explicitly. Have them explain whether they think this is genuine decline or whether retesting might clarify. Ask if they want to recheck creatinine and eGFR soon to confirm the trend. Second question: what do my other test results tell you? Ask them to walk you through your urine test results. Is there protein? How much? Your blood pressure readings, your glucose levels, your electrolytes, soon to confirm the trend. Second question: what do my other test results tell you? Ask them to walk you through your urine test results. Is there protein? How much? Your blood pressure readings, your glucose levels, your electrolytes. These paint the real picture. Third question: could this be caused by something reversible? Specifically ask, could it be dehydration, medication side effects, a urinary tract infection, recent acute illness, a medication I just started? This shows you're thinking systematically and gives your doctor a chance to address the reversible stuff first. Fourth question: if it's chronic kidney disease, what's causing it? Ask them which of the four categories applies to you: diabetes-related, hypertension-related, structural kidney disease, or metabolic lifestyle factors. Is your eGFR declining slowly, 1 to 2 milliliter mini-year, which is normal aging, or faster, which suggests active disease? If it's faster, what does that mean for your timeline? This shapes your urgency and planning. Sixth question: what should I be monitoring at home? Blood pressure, weight, fluid intake, urine symptoms, fatigue or other symptoms? What changes should trigger you to call? Seventh question: do I need to see a nephrologist or can we manage this together? If your eGFR is 45 or below, many guidelines recommend at least one nephrologist consultation. If you're declining rapidly, you might want specialist involvement. But don't ask in general terms. Ask specifically: should I change my diet, limit protein, reduce sodium, start exercising, stop taking NSAIDs? Are there medications that might help? This gives you concrete action items. The point of these questions isn't to second-guess your doctor. It's to become informed enough that you're not just passively receiving information, but actively understanding your situation and what comes next. Most doctors welcome this. It makes their job easier, and it sets you up for better long-term management. Here's what you now know. When your eGFR declines, your doctor is systematically investigating 7 main reasons: reversible causes like dehydration and medications, calculation artifacts, and chronic causes like diabetes, high blood pressure, underlying kidney disease, and metabolic factors. You know what tests reveal what information. You know what questions transform a lab review into a diagnostic conversation. You know the difference between real decline and variation. Most importantly, you know that a declining eGFR is not a diagnosis in itself. But different doesn't mean destiny. Different means investigate, understand, address, and monitor. And now you can do that from an informed position instead of a place of worry and confusion. If you found this helpful, please subscribe. We're making videos about kidney health, lab test interpretation, and chronic disease management every 2 weeks. Drop a comment with your biggest question about your own lab results or health situation. Let's build a community of informed patients.